Assalamu alaikum warahmatullahi wabarakatuh. Welcome back to the channel of Stand Medical Notes. Previously, we discussed about the acute complications of diabetes mellitus. From now onwards, we will finish the topic by completing these topics, four topics of chronic complications of diabetes mellitus. So, let's begin with the name of Almighty. So, there are four complications of diabetes mellitus. So, it affects kidney, it affects eye, it affects nerves, and it affects food. So that's why there is diabetic kidney disease, also known as diabetic nephropathy, diabetic eye disease, diabetic retinopathy, diabetic neuropathy, and diabetic food syndrome. Coming to the first topic, that is diabetic kidney disease. So what is diabetic kidney disease? Diabetic kidney disease is a clinical diagnosis characterized by persistent albumin in the urine, uh, a progressive decline in the estimated glomerular filtration rate, or both, occurring in a patient with a documented history of diabetes mellitus. In simple words, we can say it as CKD due to diabetes mellitus. CKD due to diabetes mellitus is nothing but diabetic kidney disease. So, what is CKD? It is defined as by abnormalities of kidney structure or function. So, structure or function. So, CKD is a broad term. It can be caused by many things. Okay, it can be due to adult polycystic kidney disease, or it can be due to single kidney, or it can be due to malformed kidney. That is abnormality of kidney structure. Function. It can be due to glomerulonephritis, or it can be due to analgesic abuse, or it can be due to diabetes mellitus, or it can be due to hypertension, uncontrolled hypertension. So, it is a broad term, so causes can be many. So what is actually, basically we can define CKD as abnormality of kidney structure or function present for at least 3 months with implications for health. Okay, so that is definition. How do you establish the diagnosis of diabetic kidney disease? Okay, so there should be persistent EGFR less than 60, or urine albumin creatinine ratio UACR more than or equal to 30 milligram per gram, or more than or equal to 33 milligram per millimole. So either this, or you can take both also. Persistent, what do I mean by persistent? So you take one sample, suppose on day 1, and you take another sample 3 months after day 1, 3 months after day 1. So if in both these samples, so which are taken 3 months apart, if either of these is present, either the EGFR is less than 60, or UACR is more than or equal to 30 milligram per gram, or 3 milligram per millimole, then it is known as diabetic kidney disease. Okay, so you should have at least two samples to say it as diabetic kidney disease. So why don't we call it as diabetic retinopathy? Why call it as diabetic kidney disease? While diabetic kidney disease is preferred for clinical management, the term diabetic nephropathy is strictly reserved for patients with biopsy proven structural kidney damage, such as nodular glomerulosclerosis. So once you prove by biopsy the presence of this nodular glomerulosclerosis, then you can call it as diabetic nephropathy. Otherwise, clinically you should say it as diabetic kidney disease. So why should we study this diabetic kidney disease? So the reasons are: a high epidemiological burden. It is the leading cause of end-stage kidney disease globally, developing in up to 20 to 40% of patients with diabetes, and accounting for 20 to 50% of patients starting renal replacement therapy. That means it is a very number one common cause of end-stage kidney disease, or you can say chronic kidney disease. Number two reason is systemic microangiopathy marker. So it serves as an independent predictor of other severe microvascular complications, particularly diabetic retinopathy and somatic or autonomic neuropathy. That means if there is diabetic kidney disease, then there will be diabetic retinopathy, eye involvement also, and there will be neuro involvement also. So it is a marker, systemic marker of microvasculopathy. Third reason is amplified mortality. The presence of diabetic kidney disease dramatically increases the cardiovascular disease risk, cardiovascular event rates like MI, heart failure, okay, and atrial fibrillation, and all cause mortality, making cardio-renal protection a primary therapeutic target. So this is also one reason that whenever a patient develops CKD, he has a high chances of cardiovascular events and cardiovascular mortality. Fourth reason why should we learn this, the legacy effect. What do you mean by legacy effect? Legacy effect is present actions will have effect on future. Present actions will have effect on future. For example, if you have a car, okay, if you have a car and you maintain the car from day one, you have purchased the car from store, you have a good maintenance of the car from day one, then it will work, it will give a service, very good service for a long time, and if at all, if some problem comes in the structure or parts of this car later on, then they will be minimum, because from initial only you have managed the car, very good, okay, you have maintained the car very good. So that is legacy effect. So in the context of diabetes mellitus, if you manage diabetes now very good, from initially, from the onset, management is good, then the organ systems in our body, they will have a good life, and if at all, if they develop any complication, that will be minimal, which can be handled by therapy. And if you don't manage diabetes by onset only, then by after some years only, you will have major organ system dysfunction. Okay, so that is this is known as legacy effect. If you maintain diabetes good from onset only, then organ systems will be good for a long duration of time, and if at all they develop any complication, that will be minimal and well controlled by therapy. That is legacy effect. So landmark trials establish that early intensive glycemic control results in a long lasting metabolic memory, or legacy effect, yielding persistent long term cardiovascular and renal protective benefits. Okay, same thing. So fourth reason is glycemic balance. While strict glycemic control is appropriate for young patients, aggressive glucose lowering to a target of HbA1c less than 6 or less than 6.5% in older patients with a long duration of diabetes mellitus and multiple cardiovascular comorbidities actually increases the mortality. Okay, so those patients who have a long duration of DM with multiple cardiovascular comorbidities, and you maintain a strict control of HbA1c, that will increase the mortality actually. So in these patients, the target is actually less than 7.5 to 8%. This is the target, not less than 7 or less than 6.5 in some cases. Okay, so this is proven by the trials like ACCORD trial. That is the thing. So early detection, risk factor control, and comprehensive cardio-renal protection are the cornerstones to improve the outcomes in diabetic kidney disease. So why we will develop this diabetic kidney disease? So remember two things to remember. One thing is glucose will cause toxicity by some pathways. So this is one pathway, this is one pathway, this is second pathway, this is third pathway. So this glucose will cause toxicity, okay, to the kidneys. And one thing is the blood pressure in the glomerulus will increase. The blood pressure in the glomerulus of the nephrons, okay, glomerulus of the nephrons will increase. Glomerulus of the nephrons will increase. BP of the nephron, you can say it as easy. BP of the nephron will raise, and glucose will cause toxicity in the kidneys by some pathways. So first we will discuss the increased BP of nephron. So high blood sugar what it will do, it will dilate this is the afferent arteriole, this is the efferent arteriole, and this is the glomerular complex. This will be the Bowman's capsule, okay, and here you will have some mesangial matrix, okay. So leave that. So this is the afferent arteriole and this is the efferent arteriole. So high blood sugar causes dilation of this afferent arteriole. So when it dilates, more and more of blood will enter in this. So the and efferent arteriole will constrict. So it will become small in diameter and this will become large in diameter. So more of the blood will come, but less of the blood will go outside. That will cause increased pressure in the glomerulus. Increased pressure in the glomerulus, and eventually it will cause scarring of the nephrons. Eventually it will cause scarring of the nephrons. Okay, that is the first thing. So increased pressure inside glomerulus causes intraglomerular hypertension. That's why AC inhibitor, how they act? This AC or ARBs and SGLT2 inhibitors, they act by decreasing this intraglomerular pressure only. That is the mechanism of action of this AC or ARBs, SGLT2 inhibitors. And by decreasing this pressure, they will decrease the proteinuria, albumin in the urine, in the tubules, early convoluted, what do you call, early convoluted tubule, distal convoluted tubule, and loop of Fonle. So less of the albumin will enter in the tubules, and remember, albumin in the tubule will damage the tubules. So albumin in the tubules of the nephron will damage the tubules. So if less protein enters the tubules, there will be less damage to the tubules, okay, and there will be less fibrosis. Less of the parenchyma of the kidney is replaced by the scarring tissue. So that's how this AC inhibitor and ARBs and SGLT2 inhibitors work. Okay, so that is the first pathophysiology. Okay, as said here, see, hyperglycemia causes a series of changes in the kidney that injures the glomeruli and tubules, linked to protein in urine and loss of kidney function. So more in, less blood out, high pressure in glomerulus, damage over time. Now how this high glucose causes toxicity, we will see. So number one is this high glucose, what it will do, it will produce something called as advanced glycation and products. Advanced glycation and products. What is that? Glucose will go and attach to the proteins and basement membrane of this endothelial cells of the glomerulus. Glucose will go and attach to the proteins and basement membrane, and this glucose will increase the vascular permeability. These advanced glycation and products bind to range, and that will increase the oxidative stress, inflammation, and promotes clotting. The result is vascular injury, inflammation, and thrombosis. Okay, so what happens, the one thing to remember here is, so when this basement membrane is, first of all, there will be increased thickness of the basement membrane, and the negative charge of the which are present on the podocytes. So if you remember, this is the Bowman's capsule, if this is the Bowman's capsule and this is the glomerulus, there is negative charge, actually there is negative charge here in the cells, negative charge, because of which negative will repulse. Albumin is also negative charge, protein is also negatively charged. So when this negative charge in the Bowman's capsule is gone because of this injury by glucose, so there will be no repulsion to the albumin, and albumin will be secreted in the tubules, and that will also cause toxicity. So albuminuria is a marker of kidney damage. Albuminuria is a marker of kidney damage. Okay, this is one pathway. Second pathway is protein kinase C activation. So high protein kinase C, what it will do, it will increase VEGF, vascular endothelial growth factor, that will increase capillary permeability, and hence there will be matrix accumulation and more leakage. Third pathway is polyol pathway flux. So glucose is converted to sorbitol. Sorbitol buildup causes osmotic stress, depletes myoinositol. That means patients of diabetes should take a high myoinositol and react to oxygen species. Okay, so that will cause oxidative stress and cellular injury. So overall effect of all this, there will be fibrosis. Fibrosis of the nephrons, meaning the functioning parenchyma of the kidney is replaced by the fibrous tissue, which is non-functional. That's all. So these are the two basic pathways. So now structurally or histopathologically what we will find. So early changes are in the glomerular basement membrane and mesangial matrix. So remember, so here is afferent arteriole, and this is the efferent arteriole, and this is the glomerular apparatus. Okay, and this is the basement membrane, you see. Okay, and this is the Bowman capsule. Between the Bowman's capsule and the this glomerulus, there is a matrix composed of mesangial cells. Here mesangial cells. These mesangial cells, what they macula densa, okay, macula densa, what it will do, they will sense the presence of sodium, and if sodium is less, they will secrete renin. To conserve sodium. And another function is they will secrete erythropoietin. So these are all physiology. Okay, so this is the main function. There is erythropoietin function and renin is secreted. So when there is diabetic kidney disease, because the glomerulus, there is thickening of glomerulus and the negative charge is lost, and all those things, pathological things takes place, renin is secreted very much and erythropoietin is secreted less. So what will happen? Fluid will accumulate and BP will raise in patients with diabetic kidney disease, whereas hemoglobin synthesis will fall, and there will be less production of RBCs. RBCs production will be reduced. That's why there will be anemia of chronic disease in these patients. Okay, this is all about physiology along with pathology. So let's see about the histopathology, what we will see here. So early changes are in the basement membrane of the glomerulus and mesangial matrix. There is thickening of the glomerular membrane, and there will be loss of negative charge, and there will be leakage of albumin into the urine, and there is mild increase in mesangial matrix. So because there is leakage of albumin in the urine, albuminuria more than 30 milligram per gram or 3 milligram per millimole, or in terms of, if you take protein, total protein, more than 150 milligram per gram or more than 15 milligram per millimole of this is protein and this is albumin, is the first marker of diabetic kidney disease. Okay, this is the earliest marker of diabetic kidney disease. That's why there should be annual screening of diabetic kidney disease, because it is silent and patient will have symptoms only in the late stages. Okay, so this is first, early changes. Second is nodular glomerulosclerosis. In simple terms, fibrosis will begin to develop now in the nephrons, in the glomerulus. So more mesangial expansion, formation of acellular nodular deposits known as Kimmelstein-Wilson nodules. Okay, which is pathognomonic of diabetic kidney disease. If you do biopsy, M biopsy reveals this one, then this diabetic nephropathy is confirmed. So there will be nodular glomerulosclerosis, meaning the glomerulus is now replaced by fibrous tissue. Okay, initially there will be changes in the basement membrane, and then there will be fibrosis of the glomerulus, and then there will be tubulo-interstitial injury. What will happen? Albumin in tubules acts as a toxin, triggers inflammation, and it will cause fibrosis and scarring. That will again lead to nephron loss. That is the third stage. Fourth stage is the advanced stage or late changes. So there will be global, meaning universal fibrosis of the kidneys, and the size of kidney will reduce. So which you will see, which is a late marker. So kidney size will be reduced if you see in ultrasonography. So normally it will be 9 to 10 in longitudinally. It will become some 6 centimeter size in ultrasonography. Okay, so this is a late marker. Okay, so there will be generalized fibrosis and declining EGFR. Okay, that is the late stages. Earliest changes in ultrasonography. What is the earliest change? Earliest change is you will have loss of corticomedullary differentiation. Loss of corticomedullary differentiation. This is the earliest sign in ultrasonography. Okay, we have discussed a lot in this. Now, what is the big picture? High blood sugar will call hemodynamic changes. I said no. So AC inhibitors and SGLT2 inhibitors will handle this one, and good control of glucose will handle this one. By that we will we will slow down or even stop the progression of kidney disease. Okay, that is the main applied aspect. So high blood pressure we call hemodynamic changes, then metabolic pathways, then structural damage and scarring, then protein in urine and loss of kidney function. Hyperglycemia will cause hemodynamic changes plus metabolic injury both. Okay, structural damage, proteinuria and kidney disease. So how do you manage control of blood sugar? Ras blockade either by AC or ARB, and one more is SGLT2 inhibitors. Okay, this you should control. That's about the pathophysiology of diabetic kidney disease. Now coming to the classification, there are two classification systems. So important one is KDIGO classification system, but one more classification is Mogensen classification system. So Mogensen classification system is used for the step-by-step progression of this diabetic kidney disease. So at what stage what is the thing happening in the histopathology, that is from the Mogensen classification. And KDIGO classification or KDIGO staging is necessary clinically actually. So to take action, this KDIGO classification will help. Okay, so let us see. So in this table I have integrated both classification, both Mogensen staging and KDIGO, but we will learn them differently. So stage 1 of Mogensen, so there will be early hyperfunction or hypertrophy. There will be nephron enlargement and increased plasma flow and that will cause glomerulus hypertension. Stage 2 is silent glomerular lesions, so that will cause basement membrane thickening and mesangial expansion. Stage 3 is incipient diabetic nephropathy. Now the patient will have microalbuminuria, meaning more than or equal to 30 milligram per gram albumin or more than 150 milligram per gram protein, total protein, and patient will have progressive systemic hypertension. So this is the stage where we catch the diabetic kidney disease, stage 3 of Mogensen classification, because until till then we don't have any clue of diabetic kidney disease. In this stage nothing, we don't have any proteinuria, nothing. One thing is there, in earliest stage kidney, normally the EGFR is from 90 to 120. Actually this is the normal EGFR. So there will be elevated EGFR more than 130 to 160. So that is one clue by which we can say that patient may be having maybe developing diabetic kidney disease, but that is not a reliable way. We catch this third stage by detecting the proteinuria, and if we take action at this stage, then we can even stop the progression of diabetic kidney disease. So that is the third stage, diabetic nephropathy. So that is silent diabetic nephropathy. Patient only will have hypertension, progressive hypertension. Then overt nephropathy, meaning now the patient will have symptoms. So in histopathology there will be diffuse sclerosis and there will be heavy proteinuria and edema. Heavy proteinuria and edema, meaning macroalbuminuria, or you can say meaning more than 300, you can see here more than 300 mg per kg, or you can say protein more than 150 to 500 to 1000, more than 1000 total protein, 1500, more than 1500 milligram per gram total protein. This is overt stage. Then there will be end stage, fifth stage, global sclerosis, interstitial fibrosis, and patient will have uremic symptoms. So that is about the Mogensen classification, 5 stages according to Mogensen classification. Now we will come to the important classification. So the KDIGO is dependent upon two things. One is EGFR and second one is albuminuria. EGFR is classified into stage G1, G2, G3A, G3B, G4 and G5. Okay, so G1 is more than 90, G2 is 60 to 90, G3A is 45 to 60, G3B is 30 to 45, G4 is less than 30 and G5 is less than 15. A is divided into 3, A1 is less than 30 milligram per gram of albuminuria. A2 is, or you can say less than 150 total proteinuria. A2 is 30 to 300 milligram per gram of albuminuria, or 150 to 500 milligram per gram of total protein. Okay, and A3 is more than 300 milligram per gram of albuminuria, or more than 500, if I am right. We will discuss next one. Okay, so A1, A2, A3. So whenever you are mentioning patient with CKD, you should mention the stage also. You should write like this: CKD if stage like G2 A1 or G2 A3, like this. Okay, that is the rule. Okay, that's how you should mention the stage also. Okay, let's discuss now. So see here now. So initially there will be increased GFR. Okay, but A1 is normal, A1 is normal. Here I will not detect anything. Stage 3 is EGF, means this is G1. EGFR will be normal, but A2 will be there. What is A2? Microalbuminuria, more than 30, okay, or equal to 30. So there is moderate to high risk. We can even stop disease therapy with intensive therapy. Okay, then the stage comes. First there will be albuminuria, then there will be decreasing the GFR. Here there will be G2. Sorry, it is G3. This is G3. So eGFR will fall less than 60, and albuminuria will be more than in the A3 stage. A3 stage. This is known as irreversible decline. Now we can't prevent, we can't stop. Our goal is to delay the end stage kidney disease, slow down the kidney progression. Okay, kidney disease progression we should slow down now. Whenever the kidney reaches to stage 3A, our albumin is in A3. Okay, then this is the terminal, meaning G5. Okay, this is irreversible and this will require renal replacement therapy. So this is KDIGO risk category. Okay, so same things here. Okay, KDIGO albuminuria, A1 is less than 30, A2 is 30 to 300, A3 is more than 300. So low risk of CKD progression. Moderate risk progression, we can stop the disease here. High risk, we can't stop, we should retard the progression. Very high risk and stage renal disease. Okay, then coming to, so we have studied albuminuria, but in many backward states in other parts of the world or in underdeveloped countries, you may not have urine albumin creatinine ratio. The labs will measure total protein instead. So according to that, how do you classify? You will classify A1, sorry, you will classify it as A1, A2, A3, A4. A1 is less than 150 milligram per gram. To say it as milligram per millimole, what you should do, you should reduce the zero only, that's all. In albumin also, in total protein also. So this is normal, no protein. So 150 to 500 is, this is nothing but microalbuminuria. Okay, more than 500 to 1500 is A3, severely increased proteinuria, and more than 1500, 500 to 1500, and then more than 1500 is very severe increased proteinuria. And when you call it as nephrotic range, when it is more than or equal to 3500 milligram per gram. So you should remember 4 things. What are the 4 things you remember? One is 150, 4 digits, 150, 500, 1500 and 3500 when you are taking total protein into account. Now according to that, what should be the management? It is given here in A1. So this is A1. Optimize the BP control. Use RAS inhibitor if indicated, if there is hypertension, if there is albuminuria, heart failure. Manage CVD, risk factors and lifestyle. Monitor CKD progression. Now this is microalbuminuria, this is A2. So here now the total protein is 150 to 500. So now you should start RAS, you should start SGLT inhibitors, you should have a intensive BP control, you should control glucose, okay, and you should have lipids. Why lipids we are using? Because CKD patients have a high risk of cardiovascular disease and cardiovascular event, so that's why you should start lipids. Now this is A3. A3 means 1500 to 1500. Continue RAS at maximum tolerated dose. SGLT inhibitor if EGFR more than 20.
Now you can add up this one, finerenone here. This is the third drug which we add. Finerenone, how does it act? Finerenone, what it does is, it will decrease the inflammation in the kidney. It will decrease the inflammation in the kidney, and hence it will decrease the fibrosis of the normal functioning parenchyma of the kidney. So that's how this finerenone acts. Okay, so you can add up finerenone in this stage. And A4 is again maximize RAS inhibition, agility finerenone. Okay, and measure UPCR at 3 to 4 times per year, meaning every 3 months. Every 3 months you should see. Here every 6 months you can see the patient. Here yearly you can see the patient. But we don't do like that. From here only what we do, we see the patient every 3 months. Okay, every 3 months is the stand on. So what we will do in this one, UPCR is preferred over 24-hour urine protein for routine assessment. Persistent albuminuria or proteinuria is defined as more than 2 samples over a period of more than 3 months. Higher proteinuria categories are associated with faster CKD progression, greater cardiovascular risk, both. Okay. Treatment aims to reduce protein and slow CKD progression. How do you do that? Manage the BP. Have good glycemic control. Okay. And LDL should be less than 100. Or if the patient has comorbidities, then less than 70. Okay, this is some conversion. Don't take headache. Okay, that's all about the management according to UPCR. Okay, coming to clinical features and must not miss diagnosis. So the early phase, the patient, I said typically patient is asymptomatic and the disease is silent. That's why annual screening is essential by using either UACR or UPCR. Okay. In the overt phase, meaning when the patient becomes symptomatic, patient has foamy urine, patient may have fluid overload, meaning edema in the feet or edema of the face, edema of the in the abdomen, or breathlessness. Accelerated patient can have blood pressure becomes difficult to control. Uremic complications patient can have. And remember, uremic complications, uremia, the initial symptoms of uremia are GI symptoms: nausea, vomiting, anorexia, constipation. Okay, itching. All these are uremic complications. And if patient has CNS symptoms, then that is known as uremic encephalopathy. And this is also a very important point by which clinicians catch CKD, suspect CKD. The patient will have repeated episodes of hypoglycemia on same insulin dose. Patient will not, there will be no history of increase in the insulin dose, or there will be no history of missed meals, but patient will be coming with recurrent episodes of hypoglycemia. So why? Because kidneys break down the insulin, and now the kidneys are malfunctioning and insulin is acting for a long time. That's why patient is having hypoglycemia. So that is also a clue. Okay, so there'll be fluid overload, BP will becomes harder to control, and there'll be GI symptoms. Okay, and there'll be decreased insulin requirement, recurrent episodes of hypoglycemia. Coexisting microvascular manifestations are diabetic retinopathy. Remember, very important. Up to 90% of patients with type 1 DM and nephropathy have coexisting retinopathy. Its presence strongly predicts DKD. And one point to remember is, if the patient is not having diabetic retinopathy, if a patient of DKD, diabetic kidney disease, is not having diabetic retinopathy, then you should suspect non-diabetic kidney disease. Other causes, you should suspect other causes. Patient will have diabetic retinopathy. A patient with diabetic kidney disease will have diabetic retinopathy. Okay, and also diabetic neuropathy also. So somatosensory, like glove and stocking, somatosensory neuropathy. Okay, numbness and tingling. Autonomic problems like postural hypotension, gastroparesis. Okay, neurogenic bladder. So loss of urinary droplets from urethra. Postural hypotension, when patient stands up from sitting position, he will experience blackouts. Gastroparesis, patient will have give a history that if I take small amount of food, I feel increased, my appetite is fulfilled, like that. So often occur along with kidney disease. So these are this can be mainly somatosensory and autonomic symptoms will be there in diabetic neuropathy. So these two are co-occurring with this diabetic kidney disease, that we should remember. Early symptoms, and when the patient becomes symptomatic, what will be the symptoms, and co-occurring symptoms. Now, so DKD is silent early, screen every year. Watch for protein in urine and rising blood pressure, very important. Check eyes and nerves, they often show damage together with kidneys. Early detection, control, slow progression, prevent complications. That is the take home message. So I said no. So what you should not miss? We should not miss non-diabetic renal disease, meaning there will be CKD, but that is not due to diabetes, or they can be CKD due to diabetes, but along with diabetes there can be some other cause which is causing this kidney disease. So overlap things. A significant subset of patients with diabetes and kidney injury have NDRD either alone or superimposed on background DKD. NDRD is a critical must not miss diagnosis because many causes, like important one is membranous nephropathy, minimal change disease, and vasculitis are reversible and responsive to targeted immunosuppressive therapy. The commonest one is IgA nephropathy, which we see. Okay, in NDRD I'm saying this is the commonest one. Okay, so when we will suspect that the patient may be having NDRD, so these are the important clinical red flags which will help us to identify those patients. Number one is duration of the diabetes. If the duration is less than 5 years, then you should suspect NDRD. If the patient has systemic symptoms suggestive of alternative systemic disease, mostly this MCTDs, CTDs, connective tissue disorders, symptoms of connective tissue disorders. If the patient has, then you should suspect NDRD, like unexplained fever, malar rash, SLE, hemoptysis, good posture syndrome, purpura, IgA nephropathy, active arthritis, rheumatoid arthritis, or psoriatic arthritis. So all these things will involve kidney. So almost many of the vasculitis, okay, all these vasculitis and systemic connective tissue disorders involve the kidney. Okay, systemic symptoms are, if they are present, then you should also evaluate for those causes. And this is in the history and examination you will see. Then if there is no diabetic retinopathy, then you should suspect. Now in urine examination, if you see dysmorphic RBCs or persistent microscopic hematuria RBCs, or altered shape of the RBCs, or RBC casts you see in microscopy, then you should suspect NDRD, particularly glomerulonephritis or nephritic syndrome. Second one is the protein and EGFR. If the EGFR is declining very fast, by very fast I mean more than 5 ml or more than 5 per year, every year the EGFR of the patient is falling more than 5, then you should suspect NDRD. Abrupt onset of nephrotic syndrome, so patient has having worsening proteinuria, so total proteinuria UPCR you are getting more than 3.5, more than 3500 you are getting UPCR, okay, meaning nephrotic range of proteinuria if you are getting, then you should suspect NDRD. So these are the things, okay, in history, diabetes, duration, and systemic symptoms, and when you go examination, diabetic retinopathy, RBCs in the urine, EGFR decline, and heavy proteinuria. All these 6 things, very important to remember, these 6 things will give us a clue of NDRD. Why it matters? Identifying NDRD is essential because many conditions are treatable and potentially reversible with appropriate diagnosis and targeted therapy. So I think this is enough for today. We'll discuss in the next video. Thank you.